everyone, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator for MS Focus, and I'm joined by Dr. Daniel Kantor, who will be talking to us today about Healthier You, Healthier MS. After a presentation from Dr. Kantor, we'll open it up to your questions and comments. Now I'm delighted to introduce our speaker. Daniel Kantor, MD, is President Emeritus of the Florida Society of Neurology and the founding president of the Medical Partnership for MS and the Real-Time Neurology, and is an associate scholar at the University of Pennsylvania Center for Global Health. He is an active member of the Healthcare Advisory Committee of MS Focus, MSAA, and MS Views and News. He is the chief medical correspondent of MS Insight, and for a decade, he served in that role for MS World. He is the co-scientific director of the largest US-based MS patient registry, Corona MS. He is chair of the Sports Medicine Advisory Committee of the Florida High School Athletic Association's Sports Medicine Advisory Committee, and is the past chair of the Florida Medicaid Pharmacy and Therapeutics Committee, past director of the Comprehensive MS Center at the University of Florida, Jacksonville, inaugural Neurology Residency Program Director at the Schmidt College of Medicine, Florida Atlantic University, and the past Chair of Education and Board Director of the Southern Headache Society, and past Vice Chair of the American Academy of Neurology's Sports Neurology Section. Dr. Kantor is board certified in neurology and headache medicine, and he practices in South Florida. We're very pleased to have him join us and to present this wonderful topic. Dr. Kantor, thank you so much for being with us today, and now I'll turn it over to you.
Thank you very much for having me. It's a pleasure to be here with the Multiple Sclerosis Foundation, or MS Focus. For a long time, many of you know that the Multiple Sclerosis Foundation, MS Focus, has focused on motivating, educating, and empowering. It's all about me. Well, another way of thinking about that is it's all about you. And so if you want your MS to be as good as possible, you need to make sure that the rest of you is as good as possible. What do we mean by that? Well, before we get into the details, let's first make sure that we're all talking about the same thing. When we think about multiple sclerosis, we think about a diagnosis that is lifetime for a lot of people. What that means is that while things may come and go, or they may stay around, or they may go away for a while, it's a diagnosis that people live their lives with. It's not a reason for people to stop working. It's not a reason for people to stop doing the things they enjoy. It's not a reason for people to stop having families. It is a reason to focus back on yourself. And what I've been finding is that people with multiple sclerosis, as well as with other neurological diagnoses, are actually often more centered and more mindful about who they are in this world. What we've all learned throughout this past year and a half of the COVID-19 epidemic is that people with comorbidities, so people with other conditions, people with high blood pressure, people with obesity, people with heart disease, other conditions can make you at a higher risk of having bad effects of COVID. And so what that tells us is that it makes sense to make sure that all those other conditions are doing as well as they can be. Now, that's not just true when you're talking about a global pandemic or an infectious disease. That's true when you're talking about multiple sclerosis as well. When somebody has MS, it doesn't protect you against all the other things that can happen in life. It doesn't protect you against accidents that happen, doesn't protect you against heart disease, it doesn't protect you against high blood pressure, it doesn't protect you against high cholesterol. All those things can still be happening. But if you keep those other conditions as healthy as possible, then what you do is you make sure that your MS is as healthy as possible as well. So how do you do that? Well, one of the ways of doing that is to really sit down and write down a list. And write down a list of how you're doing. And say, well, what are the issues that I'm having? Whether they have to do with MS or whether they don't have to do with MS. What are those issues? Is it that I'm having problems with sleeping? Is it that I'm not sleeping right? You know, the most common reason for sleeping problems in America has to do with poor sleep hygiene, meaning that we should be using the bedroom for two things, and one of those things is to sleep, and the other one isn't to eat or drink or watch television. And so many of us, we don't have good sleep hygiene. We don't go to our bedrooms at nighttime and have restful nights of sleep. If we don't have a restful night of sleep, then that means our body can't be energized for the next day. That means that we can't do better the next day. And so when you're writing down your list, what's important to write down is not just what's affecting you in terms of your multiple sclerosis, but also what's affecting you in terms of the other conditions that are going on. Some people may have high blood pressure. If you have high blood pressure, your physician, your nurse practitioner, your physician assistant, they may tell you that you should be checking your blood pressure and that you should be changing your diet and changing your exercise routine, making sure that you have aerobic exercise, making sure that you try to do things to try to reduce that blood pressure. Long time of having high blood pressure can be bad, not just for our heart, not just for our kidneys, it can be bad for other things like our brains as well. And so that's why if a person has multiple sclerosis, it's important to make sure that the other conditions like high blood pressure, like heart disease, like diabetes, are all managed appropriately. It's only by managing those things appropriately that people with MS can do the best they can do. Now, why is that? Well, it's because MS doesn't affect you in a bubble. MS doesn't say, well, I'm only going to affect the central nervous system. And because I'm only going to affect the central nervous system, it doesn't matter what other conditions you have going on. All the different parts of our body really play together. And that interplay is what can lead to good health, but it can also lead to illness. And so if you have multiple sclerosis, but for example, you have diabetes as well, and your diabetes isn't under good control, then what's going to happen is your MS isn't going to be under good control either. And so while you're trying to make sure that your MS is doing as well as possible and your neurologist is working with you, you're not taking care of your diabetes, and so your MS isn't doing as well as it can. And that's how all these things really play together. You know, over 100 years ago, when they were in the 1800s, they started talking about different kinds of doctors for different parts of the body. And at the time, physicians thought that this was ridiculous. They thought it was crazy that one day you would have a doctor that would take care of your stomach, and another time a doctor would take care of your lungs, and another doctor would take care of your bones. Now we call those gastroenterologists, we call pulmonologists, orthopedists. We have all those types of physicians because we realize how complex the body is and really how health and disease can show up in different people in different ways. When we focus on those things, a lot of times people focus on just the medical conditions, the things that I've mentioned. I've mentioned high blood pressure, diabetes, heart disease. But what about conditions that we don't generally think of as medical conditions, but we think of them as thinking conditions or cognitive conditions or even psychiatric conditions? What do I mean by that? Well, your mind and your brain help you do many things. They help you move, help you lift one arm, move the other arm, feel that sensation, have those reflexes when the doctor's checking you. But what it also does is make sure that the motions that you're feeling are going in line with what the external stimulus is. What I mean by that is that when somebody is going throughout their day and things aren't sad or happy, they should be feeling fine. Nothing bad happened that day. And you would think that a person would be feeling okay. They woke up in the morning, they took a breath of fresh air, they were able to work, they were able to take care of their family, they were able to interact with those around them. But for some people, life can be a lot harder. And life can be a lot harder because it's not just about the things that you're trying to do. It's also about how you're interacting with those conditions. So what does that mean? Well, if you're not feeling that good inside and people around you seem like they're going along their day fine, then you may be feeling sad inside. If you're feeling sad inside, that may continue and it may get worse. And if it happens, you may have feelings of either hurting yourself or hurting other people, or thinking that things are not worthwhile or that things aren't meaningful. When you start to have those feelings, we call that depression. Now, at other times, people may have thoughts of grandeur. They may think that things are going amazingly, and they may think things are better than they seem to outsiders. And they may start talking more and more, and they may start doing more and more, and they may start gambling, they may start buying things, and they may start interacting with the world in a more robust way than the people around them. When that happens, we call that mania. And so sometimes some people can be having periods of depression where things feel sad and things feel happier, feel mania. And when that happens, we call that bipolar disorder. Now, that can happen with multiple sclerosis or without multiple sclerosis. And it could be that in a person with MS who has these feelings of highs and lows, that it's related to their MS. But at times, it may just be that there's two conditions that are going on at the same time. And the only really way to deal with these things is to take them head on and not to bury our head in the sand and to not focus on them. And the only way we're able to do that is if we actually talk about it. And one of the things that we haven't done for many years was talk about those things. For a long time, people didn't talk about how someone was feeling on the inside. You were expected to be that model mother, or that model father, that model brother, that model sister. You're expected to be that person out there as that rock for your family. And you may not have been able to do all those different kinds of things. It's only through talking about it that we're able to raise more awareness. That's why I'm so happy that the Multiple Sclerosis Foundation joined with other MS organizations. And through the MS Coalition, through the organization of non-for-profits dedicated to multiple sclerosis, they took a focus several years ago actually on mental health and said, it's not just important for us to focus on physical health. It's not just important for us to focus on multiple sclerosis. It's important to focus on mental health as well. Because when we don't do that, when we don't focus on it, well, then people don't talk about it. And when people don't talk about it, we're not able to move that individual forward, and we're not able to move the field of multiple sclerosis forward. And that's why I challenge each of us to really think about ways that we can raise more awareness and talk more about not just physical health and not just about physical healthiness and physical well-being, but also about mental health and mental well-being. So what are the treatments that we use to deal with mental health? Well, the first part is to make sure that it gets diagnosed. And the person who's going to diagnose it is going to sometimes be your primary care physician, sometimes be your nurse practitioner or physician assistant. Other times it may be the neurologist. Other people may have the ability to see an actual psychologist or psychiatrist who may be able to make that diagnosis. And in many states, licensed social workers can actually also act in terms of therapy as well. And many people belong to religious communities, and there's pastoral counseling, and there's other people who are involved in that mental health world who can help to be involved in the diagnosis of conditions that affect mental health. And once that diagnosis is made, then we can start to talk about therapy. So there's various ways that there's therapy. On the one side, you have what we call talk therapy. Now, talk therapy, some people may be familiar with kind of the old way of thinking of Sigmund Freud, and you're lying on a couch and you're talking about what happened in the past to your parents and how that may have affected you. That's one aspect of dealing with mental health issues. A lot more commonly, especially nowadays, we use something called CBT, or cognitive and behavioral therapy. And so by using cognitive and behavioral therapy, we're able to work with a person, go through different exercises, tackle the mental health issues that may be going on, and try to make things somewhat better. Now, sometimes and often, CBT or other types of talk therapy aren't enough. And in that case, we think about different treatments. Well, the first types of treatment for us to talk about are oral therapies. So our medications that people may take to try to help with their depression or with their mood. And there we think about antidepressants. Now, there's different types of antidepressants. Some of those antidepressants are going to work on different types of neurotransmitters, so different types of chemicals that are in the brain. Oftentimes, they work as serotonin reuptake inhibitors. We might also think about norepinephrine reuptake inhibitors. So these are types of neurotransmitters or chemicals in the brain that we think can be involved in depression. Some of the older types of antidepressants we may use are ones called tricyclic antidepressants. And people may have heard of medications called amitriptyline or nortriptyline. So Pamelor or Elavil, different types of medications that people may use for depression. But sometimes those aren't enough. They also may not be enough if a person isn't just having the depression, but also having those periods of mania where things are feeling too big and people are out there spending money, having grand thoughts, thinking that they can do more than they can do. In those cases, what we want to do is we actually want to stabilize the mood. We don't just want to bring the mood down or up, we actually want to stabilize it. So an antidepressant, you're taking someone from a depressed mood and you're trying to raise the mood. But if somebody has a propensity or they have a tendency for that mood to get even higher, then what you're going to want to do is you're going to want to stabilize it. And so sometimes we use some of the older medications. We use medications that have been used also for anti-epilepsy, so against epilepsy. So a medication, for example, like Depakote or valproic acid. We may use a medication called lithium to try to control that as well. And what we may try to do is to stabilize a person's mood so that they're not having these absolute highs and these absolute lows. And so that a person's mood can be more stable, not so it can be flat, but so that it can be more stable in terms of how they're doing. Now, sometimes oral medications are enough, talk therapy isn't enough, and we have to think about other ways of treating mental health as well. And that's when we think about some of the newer ways of doing what we used to do. What do I mean by that? Well, some of you may have read or seen the movie One Flew Over the Cuckoo's Nest, and people may be familiar with electroconvulsive therapy. It's not a therapy that's used in many places, but it is still used in cases where a person really needs more than oral medications, more than talk therapy, and really needs to get themselves out of those periods of depression. What's happened more recently is that we've figured out that we don't have to give electricity to make a person have what we call electroconvulsive therapy and actually cause almost like a seizure-like activity in the brain. We can actually use magnets to do that. And that's when we'll use something called TMS, or transcranial magnetic stimulation. And the idea of TMS, or transcranial magnetic stimulation, is that by focusing on certain areas of the brain, by changing the magnetic strength, you're changing the electrical activity in those areas in the brain. And then hopefully by changing the electrical activity, what you're going to do is actually change the function. All of these treatments that I've talked about can't even be started to talk about if you don't bring the issues that you're having to the forefront. And that means that you have to talk to the loved ones around you. In multiple sclerosis and MS, we talk a lot about a care partner, not a caregiver, but that loved person around you, that person who's closest to you, whom you together have a partnership in life. And it's important for you to bring up issues as they're happening early on, because only by dealing with things early on are we able to help move a person forward. What we've talked about thus far has to do with a person's mood. Sometimes people don't have a problem with their mood, or they may have a problem with their mood, but they also have a problem with the way they're reflecting or the way they're expressing that mood. Many of you heard me talk about this in the past. We call that pseudo-bulbar affect, or PBA. And the idea is that when a person is not feeling on the inside the way they're expressing it on the outside, that disconnection we call PBA, or pseudo-bulbar affect. So for example, a person may be feeling fine, but they may start chuckling a little bit. Or a person may be feeling fine, but they may start weeping or crying a little bit. It's not that they're feeling so sad that they want to cry. It's that they're expressing crying. And so it looks like they're sad on the inside. But if you ask the person how they're feeling, they say, well, I'm not feeling that way. That disconnection we call PBA, or pseudo-bulbar affect. That can happen in people with multiple sclerosis as well as people without multiple sclerosis. And what that means is that other people around you may look at you in a certain way and think that you're feeling a way, but that's not the way you're feeling. And that's why my biggest recommendation is to really write down the ways that you're feeling. If you write down the ways that you're feeling, then you can express those feelings to other people. You can say, well, I'm not feeling good, or I am feeling good, or I'm feeling sad, or I'm feeling happy. And you can let other people know about how you're doing. What we've talked about thus far is that when a person has MS, they have many things going on around them. So a person with multiple sclerosis has those general medical conditions, and some people with MS are lucky enough not to have them, but many of us, as we age, we get high blood pressure, we get cholesterol, we get diabetes, we get all the different kinds of things that happen in life. And that's true of people with MS and people without multiple sclerosis. Then what you have is you have specific things that can affect people's mental health, the way people feel on the inside, both in terms of how they're feeling on the inside, as well as that idea of pseudobulbar affect, what they're expressing on the outside. So with that as a backdrop, how do you make sure that you have the healthiest you possible? Well, the way to make sure that you have the healthiest you possible is to not just focus on the multiple sclerosis, is to focus on those other conditions as well, to write them down, to write down a list of what you're doing to treat them and what your goals are. For example, we said that you had high blood pressure. Well, it's a good idea to write down, well, I have high blood pressure. My goal is to reduce that blood pressure. How am I going to do that? Well, one way of doing that is to take antihypertensive medications, so high blood pressure medications. Another way of doing that is to fix your diet, is to make sure you're eating more healthy. Another way of doing that is to make sure that you have good exercise, is to make sure that you're exercising as fully as possible and pushing yourself, but not pushing yourself to the point where you're not able to function afterwards for a long time. Some people with multiple sclerosis, and many people with MS, it's true of that, have this idea of UTAS phenomenon, where if you get overheated, you can feel exhausted or you can feel like older symptoms coming out. When you exercise, you don't want to be pushing yourself so hard that you get to that point. But you do want to be pushing yourself hard enough that you feel your heart racing, that you feel like you're actually breaking a sweat, like you feel like you're actually getting some advantage of that exercise. Now, some of you at home may be thinking, well, that's nice. You talk about diet and exercise. Those sound like great things, but do we really have any information that shows us that's true? Well, it turns out we actually are getting and continue to get information from the scientific literature that both diet and exercise are important, not just in your general health, but in multiple sclerosis as well. Let's start with exercise. So with exercise, what we think about is, should this be aerobic exercise? Should it be what we call anaerobic exercise, which means lack of oxygen? Should it be body lifting, weightlifting, bodybuilding kind of exercise? And it turns out there's actually been studies that looked at even just using a treadmill, and that treadmill exercises not only help people with multiple sclerosis in terms of their general health and in terms of their being healthy and being able to function, it actually helped with cognition as well. It helped with thinking abilities as well. And so we see that exercise is not just useful in terms of what it can do in terms of toning your body and in terms of getting you as healthy as possible, but also in terms of how it actually helps you with your thinking. Well, what about diet? Well, if you go to social media, every day you're going to see a different kind of diet fad that's going to be out there. And the question is, which ones make sense? They did a study on the West Coast several years ago, where what they actually did is they took people with multiple sclerosis and they randomized them, meaning some people got the treatment and other people got the treatment later. So they delayed the treatment. And what was that treatment? Well, the treatment was a low-fat version of the vegan diet. So it's called the vegan Mcdougall diet. Vegan means no animal products, and Mcdougall means no fun, meaning a low-fat version of it. And what they found at the end of the year was that the people who did that type of diet they had not just an effect on their blood pressure being lower, on their cholesterol being lower, on their weight being lower, they actually had less MS fatigue as well. And so while things like MS relapses, disability, MRI didn't change, what did change are all the general aspects of a person's health, as well as the MS fatigue as well. And so it looks from the data that we have that diet is not necessarily curative in multiple sclerosis, but that diet can actually be beneficial, especially in terms of helping certain symptoms that people may have. And people often ask, well, what are some good dietary recommendations? It's hard to stick to a strict diet. Well, let's start with some simple ones. Gluten. So gluten is that protein that's found in a lot of the grains. When you think about wheat and barley and other types of grains. Gluten is a foreign protein, meaning it's not a part of our body. And in some people, what happens is they actually attack that gluten. Now, when someone really attacks it in their gut, then they have something called celiac disease. But for other people, it can make them feel just not so good. It can make a person feel more fatigued, can make a person feel more wiped out, just not as good. And there's probably less beneficial effects of gluten in your diet than there are the untoward or the bad effects in our diet. And so gluten doesn't necessarily make sense as something that we should have a lot of in our diets. Well, how about milk and dairy products? Many people love dairy products. Well, dairy's another foreign protein. So here you have, cow's milk that a person is drinking or consuming in cheese. Many people have shown the pro-inflammatory effects, meaning how inflammation, so how swelling and angry types of both T and B cells can happen from the consumption of dairy products. And so minimizing dairy products as much as possible makes sense in multiple sclerosis. How about animal products in general? How about things like eggs? Well, eggs, it's interesting. Every decade, we seem to go back and forth with this idea of, is it bad cholesterol? Is it good cholesterol? Is it good for you? Is it bad for you? It's unclear that eggs have a really beneficial effect in our diet. And for some people, they can have a lot of allergic reactions to eggs and to products that contain eggs. And if you don't have a full allergic reaction, it could make a person just not feel as good. How about in terms of red meats? Well, red meats, once again, like these other products, are things that we don't necessarily need to have in our diet. It makes a lot more sense to think about fish and seafood in terms of bringing in that protein. And so looking for protein, not necessarily from animals, but looking for protein from plants around us, looking for protein from fish and other seafood can make a lot of sense in people's diet. And then comes the question that a lot of people have, which has to do with alcohol. Now, alcohol is interesting. Alcohol has been around for a long time. Human beings have fermented every kind of food they can think of in order to make alcohol in almost every single culture. And what the researchers showed when they looked at the what's called the NOMAS study, when they're looking at the Northern Manhattan stroke study, is they looked at something called the J-shaped curve. And this is looking at it in terms of stroke prevention and in terms of risk of stroke. And so what it looked like was if you had 0 doses or 0 glasses of alcohol a day, you were at 1 risk. If you had 1 to 2, then you were at lower risk. You start to get to 2 to 3 to 4 to 5 to 6, you start to really increase your risk. When we look at dementia and the way that people think, the more you drink alcohol, the more we think that dementia happens as well. And there are some people that believe, though, that very small, very moderate amounts of alcohol could actually be beneficial and could be beneficial to the human brain. I think the jury's still out on that one. I think people have to look at the overall question of whether alcohol makes sense in their life or not, of whether it makes sense to keep it there, or whether it makes sense to not have it there. So now you've taken your health and you're looking at your exercise, you're looking at your diet, you're looking at each of your separate medical conditions, and you're figuring out how to optimize each of those medical conditions. Then what can happen, hopefully, is that all of that together can help to maximize your multiple sclerosis. So by having a healthier you can have a healthier MS. But what are some things that you can do for your multiple sclerosis itself? Well, unfortunately, multiple sclerosis does not have a cure. It doesn't mean that we won't have a cure. It just means that right now we don't have a cure. And we think of multiple sclerosis as this lifetime autoimmune diagnosis, meaning that the body attacks itself. And one of our goals is to stop the body from attacking itself. One of the key questions about MS that's still a raging debate and still a question that we don't fully understand is whether there are even really different subtypes of multiple sclerosis or not. What do I mean by that? You might be surprised because many of you may have said, well, I have relapsed and remitting, or I have secondary progressive, or I have primary progressive. I'm a different type of multiple sclerosis. Well, it's not entirely clear that MS is really all these different types of diagnoses. It may be that MS overall is more similar in different individuals than we had thought previously. What we think happens in MS is we think that there's not just this inflammation that happens, not just the swelling that happens, and when it gets too big, that's going to lead to either an MRI change, either a gadolinium-enhancing lesion, or a T2 hyperintensity, or it's going to lead to that and a relapse, where you have new or worsening symptoms. But there's also the other part of MS that's going on. That MS is not just about the inflammation that's going on, it's that the nerves themselves, as well as the covering of the nerves, can slowly be doing not as well. And we call that neurodegeneration or progression when we're talking about it clinically. And oftentimes people ask, what's really the difference between relapses and progression? And the way I tell people to think about it is not really so much what the symptom is. It's not what you're having that tells you whether you're having a relapse or whether you're having a progression. It's really that slope. It's that speed of how it's happening. So for example, if you're not walking today like you did 5 weeks ago, you're probably describing a relapse. If you're not walking today like you did 5 years ago, unless you can really kind of isolate when that happened, you may be talking about a slower sort of progression that happened. But even within that slower progression, it's not entirely clear in people how much of that is because of this neurodegeneration of the nerves themselves being damaged and the covering of the nerves being damaged, or whether there's this low-lying inflammation. And what I mean by that is that there's these T cells and B cells, these parts of the immune system that get angry and that are attacking you at a slow rate. And that's why the best we have is to use the disease-modifying therapies that are currently FDA approved. Now, these FDA-approved medications are mostly FDA approved for relapsing forms of multiple sclerosis. It used to be that we had a lot of debates about what exactly that meant and what that FDA approval was. Well, about a year and a half, 2 years ago, the FDA clarified it and clarified what relapsing forms of multiple sclerosis is. Relapsing forms of multiple sclerosis should include clinically isolated syndromes, so that first attack of multiple sclerosis, as well as that most common type of multiple sclerosis, which we talk about called relapsing remitting multiple sclerosis, as well as active secondary progressive multiple sclerosis. And those are people who may be having progression happen even in between these relapses, but they're still having some activity. So still having either relapses happening, so either clinical attacks happening, or MRI changes that are happening that are showing that there's still an inflammatory process. The reason why so many of our medications are focused on that is that the medicines, what they're doing in different ways is affecting the immune system. So some of the older medicines, what they did is they changed the type of immune cell, the type of what we call T helper cell that's happening. And they moved us from a T helper 1 to a T helper 2. Just a fancy way of saying that we shifted the way the immune system is reacting in multiple sclerosis. Then we had some medicines that what they did is they kept those immune cells. They could be angry, but if they stay angry outside the central nervous system, outside the brain and spinal cord and optic nerves, then they can't cause that kind of damage. And so they're keeping them either by blocking at the blood-brain barrier, so that barrier between the brain as well as the spinal cord and the rest of the body, or by keeping those white blood cells sequestered, so keeping them tucked away inside lymph nodes and other kinds of lymph organs. Then we've had some medications that what they actually do is they go and they have a more profound effect on the immune cells. And so that more profound effect could be, in one case, we have a medication that what it actually does is it brings down your white blood cells in general. And then as your white blood cells come back, hopefully they come back in a way that was different than the way that you had in the way that they were right before they were taken down. Meaning that they're not going to be attacking you in that same way, but they may be functioning in a better system. Other types of medications are going to actually push down a certain type of those white blood cells. So they may push down not just T cells, but actually these B cells. And this is just a part of the immune system. And the idea is that by doing that, they're reducing that inflammation that is going on. So that's where we are in terms of the disease-modifying therapies. And what you're going to continue to see for the next several years is every year you're going to see 1 to 2 to 3 new medications that comes out. And those medicines, some of them are more similar to older medicines, and some of them really have new different ways of affecting the immune system. And when each of those medicines comes out, the idea is that there may be people who that's the right medicine for them. One of the things we need to do better in the MS world is be able to have predictive ways of figuring out which medicines are right for which people. Which medicine makes sense for you versus for your neighbor versus for your friend. And that's something that we're working on hard in the multiple sclerosis arena. Researchers are working here in the United States, as well as outside the United States, in order to get there. What we've talked about is disease modification, how we can actually change the course of multiple sclerosis. But remember, we could be changing the course of multiple sclerosis, but if we don't keep you as healthy as possible, so if you're not watching your high blood pressure, your cholesterol, all the other medical conditions, then it's going to be very hard for your MS to do as well as it could possibly do. Now, when we're thinking about MS treatment, we don't only think about disease modification, we also think about what happens during a relapse, what happens during an attack. And unfortunately, we only really have two main areas that are FDA approved to shorten the amount of time that a person has an attack or a relapse of multiple sclerosis. And so that's where we're going to be thinking about things like corticosteroids, so things like steroids, as well as adrenocorticotropic hormone. And the idea is, what can we do to squash or to kind of push down on that inflammation, on that swelling that's happening? Then the other part of treating multiple sclerosis is to, of course, treat the individual symptoms that people may have. And so people can have symptoms that can be as varied as multiple sclerosis. So one person, it may be affecting the way their arm is moving. Another person, it may be affecting their sensation. Another person, it may be affecting the way they might be shaking. Another person may have a balance problem. Another person may have a visual problem. Different people can have different symptoms. And that's why one of the things that you spend time with your neurologist doing is looking at your individual symptoms and trying to figure out how you can fix them as well as you can. And how can you get them functioning and those symptoms pushing down as much as possible so that you can function and have as full a life as possible. What we've talked about today is about how being as healthy as you can help your MS be as healthy as it can be. And being as healthy as you can be involves not just physically being healthy, it means mentally and emotionally being healthy as well. I want each of you to really think hard about the different conditions that you may have and the different issues that you may have, whether they're related to MS or not related to MS, and to really tackle those. Set yourself a weekly goal and say, I want to tackle these 3 issues this week. I want to get better about my high blood pressure, about my depression, and about my sleep apnea, for example. And work on those issues, and then come back to that list. Come back a couple of weeks later and say, well, where are we now? What are the next 3 topics that we have to do? And it's only by doing that that you're going to keep yourself as healthy as possible. Realize that with multiple sclerosis, you are definitely not alone. There are a lot of people with multiple sclerosis out there, just like you, ready to help you. There are people on different social media chats. There are people on, it's interesting, we're not in such a live environment where people are necessarily having live support groups. But in multiple sclerosis, you have a mixture really of things that are going on online, as well as things that are happening in person. You have not-for-profits. You have large ones as well as small ones that are there to really help you and help get you closer to the resources that you may need. Remember, though, that the biggest resource you have is really you. The biggest resource you have is for you to sit down and to just take a breath and think about what is going on. Life seems to be moving so fast for all of us. But I think if anything that COVID's taught us is, for all of us, we just need to take a breath of fresh air and think about where we are and where we're going. With that, Deborah, I'd love to open up to any questions that people may have.
Thank you. Wow, that was a lot to think about. You covered a lot. Thank you. That was great. Okay, well, let me give you some directions for those that aren't familiar with the platform, and those that are. I'll do it again. Now we're ready for, if you'd like to send in a question or a comment, all you have to do is raise the hand feature in the app, or you can send your question via chat. To raise your hand, you click the screen to pull up the menu. You select more, which is the little icon with the three dots, and you click raise hand. I'll unmute you, and then a button will appear on your screen asking if you want to allow me to do that. And then you'll have to say yes. You select allow. And we can go from there. Let's see. I know we've changed a few things, so I want to make sure that I'm looking at the right screen. Okay, so far nothing, but I'd like to ask you.
Deborah, we do have a question under the Q&A.
Ah, yes. Okay, thanks, Casey. Let me look under that. Okay, so Judy would like to know, what is your opinion about ketamine and MS depression?
The question was about the use of ketamine as well as depression that happens in multiple sclerosis. So ketamine, some people like to call it vitamin K. It's different than the regular vitamin K. But the idea of ketamine is it's a strong medication that can actually, in a way, disassociate people. And what that means is that a person's mood can really be affected profoundly by ketamine. And there are ways now that they're trying to deliver ketamine IV into the vein. There's ways even intranasally to deliver ketamine as a strong antidepressant that, instead of what we normally think with antidepressants, that you have to wait several weeks until it starts working, or even several months, that it can really have a profound, fast effect. And so ketamine in the right hands is actually a type of medication, type of intervention that can really be used for severe depression in a fast way, whether somebody has multiple sclerosis or doesn't have multiple sclerosis.
Thank you. There's another question from Camila. Let's see what that one is. I don't see it, but let me go back into Q&A again. Any advice, this is what Camila is asking, any advice you would give to a spouse that is trying to support her newly diagnosed husband with MS?
The question was if there's any advice for a spouse who's trying to support her newly diagnosed husband with multiple sclerosis. Well, there's several things to break apart here. First is that you're talking about someone who's newly diagnosed, so someone with a new diagnosis, which means that the person beforehand, either they were having symptoms or not having symptoms, but they didn't have a diagnosis of multiple sclerosis. And multiple sclerosis may be the largest condition or the biggest name in terms of the conditions that they have. They may now have heart disease and liver disease and other kinds of problems, and really MS may be that first diagnosis that a person has. So there's that aspect. There's also the aspect that it's a husband, which means it's a man with multiple sclerosis. And when we think about people with multiple sclerosis, we think that about 60 to 70% of people with multiple sclerosis are women. And what that means is that a man with multiple sclerosis can oftentimes feel like they have a diagnosis that doesn't belong to them. That's a woman's diagnosis. They look at the images that they see on social media, or the images that they see online, or the images they see in books, and they can seem to not really be related to them. Now, also, men oftentimes feel this responsibility to be the, maybe the primary breadwinner, in some families, only breadwinner, but to be there and to be the rock for the family, and taking away aspects of how they're feeling could make them feel in a way less manly. And that's obviously not a way that we want someone to be feeling. Men often also are less able to talk or less taught to talk about how they're feeling on the inside. And so my advice for a wife of someone who was just diagnosed with multiple sclerosis is to sit down with your husband, to do those things like writing down how they're feeling, but to do that even together. To realize that maybe at first your husband may not want to do those things. He may not want to do them alone. He may feel like he has to shoulder the burden by himself. And so it's important for you to actually verbalize and say, no, honey, we're in this together. It's not just you with multiple sclerosis, it's us as a family. And the only way all of those things can really happen is if you just really have an open conversation with the person in front of you. And so whether it's a husband with multiple sclerosis, whether it's a wife with multiple sclerosis, it's important for you just to sit down together and to realize that you're taking on this next challenge in life together.
Thank you, Doctor. Before we go off of that topic, and we have some more questions, but I have a gentleman named David who has his hand up, so maybe he has something to talk about or to ask you regarding that. So go ahead, David. Why don't you go? Let's see. There you go. David, I've asked you to unmute. Let's see if that'll work.
Hello.
There you go.
Hi, Dr.
Hi.
Thank you. This conversation is so good and encouraging to me to just continue to write down what it is that I may have MS, but so many other things can occur. Now, I have been living with MS for 24 years, and I had hypertension or high blood pressure. My neurologist placed me on these medications for many years. And I got tired of taking those. And I said, okay, I have to change my lifestyle. I have to change this and that. And so I stopped eating processed food. I stopped going to fast food. I stopped doing this and red meat and so forth. And I'm not on the pressure medication no more. I'm exercising more. And because of COVID, I exercise 6 days a week for 30 minutes. And so those things that you talked about, I am doing it, and I'm going to do even more, even with the writing down. And I just thank you so much. And so that's my comment, and say that I am adhering to a lot of what you're saying. So thank you.
Thank you. Writing things down is a lot more important than people think. People sometimes think that we write things down for many reasons. One reason we write things down is to remind ourselves of something.
Yes.
Another part of writing things down is that you're actually, in a way, verbalizing it, right? So to construct language, to write it down, you have to say it in your head, and then you have to transmit that into the actual writing that's happening. It's actually a reason why it looks like there may even be better writing things down than typing things. When we're typing things, some studies have shown that what we're doing is we're just, we're hitting the letter A or the letter D or the letter S. But when you're actually writing it, you're forming that letter. And so you're really integrating it more into your consciousness.
Yes.
And so taking that pause, taking that time for yourself is really useful. And so I really congratulate you.
Yes, that is really good. And that's what I said as to other MSers as well, that when I go to see my neurologist, I write down all of the things that I'm thinking about or I'm considering, and I'm writing down a lot of things to see what his thought process is or stuff like that. So the writing down is very important, and that is key.
Thanks, David. Thank you. Sandra would like to know if you believe we'll need booster COVID vaccines and how safe are these when taking MS medications such as Ocrevus?
So now to talk about something completely different, to talk about COVID-19, SARS-CoV-2 vaccinations and multiple sclerosis. Well, right now in the United States, we have 3 types of vaccinations that have emergency use authorizations, or EUAs. So 2 of those vaccinations are what we call mRNA vaccinations, and another one is what we call, it's an inactive or a dead virus vaccination. So kind of more similar to other types of vaccinations that we have. So when we talk about the Pfizer/BioNTech and the Moderna, those are mRNA vaccines, and then we have the Johnson & Johnson vaccination, which is that vaccine that you just take once. We're only now at a point where I think about 60% of Americans have actually received the vaccinations, and not even necessarily their complete course of the vaccinations. And so it's not clear yet how frequently people are going to need to be vaccinated against SARS-CoV-2, against COVID-19. It's not clear whether you have multiple sclerosis or whether you don't. In the trials from what Pfizer has done and BioNTech and Moderna and Johnson & Johnson, they're doing booster vaccinations 6 months later to see if that helps in terms of reducing reinfection. We still don't even understand whether what's happening now in the rest of the world, especially if we look at places like India, which is obviously going through a lot right now with COVID-19, whether what we're going to see are any kinds of mutations of the virus or any other strains of the virus that are going to change what's going on. And so we don't know fully whether everyone is going to be getting boosters, and we certainly don't know what that means for people with multiple sclerosis. Now, you asked a question specifically about a medication called Ocrevus or ocrelizumab, which is a medicine that depletes what we call the B cells. So there's a type of the immune cells that get active in multiple sclerosis. But B cells, we also think about when you think about antibodies being formed. And many of us know when we think about vaccines that we think about, you inject something into a person and then the person fights it off and you form antibodies against that foreign substance. Well, if you don't have enough B cells, the question is, can you be forming enough of those antibodies to fight off other SARS-CoV-2 infections or other COVID-19 infections? And some of the data, looks like perhaps with ocrelizumab or with Ocrevus, that may be reduced. That by reducing your B cells, that you're actually reducing your ability to have protective antibodies when you're fighting off a virus. At the same time, something that makes it more complex is that antibodies are just one part of fighting off a virus when you get a vaccine. There's also not just the B cells that are important, but the T cells. And so if the T cells are still working, then perhaps you form T cells that have a response against the vaccination. And that's why some of us are doing clinical studies to look at this question in multiple sclerosis. Because the truth is, there's still a lot we don't know. I don't think it's just for MS we don't know. I think there's still a lot we don't know for the general public as well.
Doctor, I know we're on the hour. Do you have time for another question or two?
Sure.
Okay. So we have a question from Navneet, I believe her name is. I'm 20 years old, diagnosed with MS 2 years back. I have tried many oral meds, but we still find new lesions in my MRIs. Wanted to understand what might be the reason for the progression, even when I'm taking meds on time and eating right.
The question was a person who was newly diagnosed, but been taking different types of medications, and it sounds like some of the oral medications, the oral disease modifying therapies, still having lesions on MRI. What's the reason for that? What I want for people to take away most from this is that we don't say that's continued progression. We have to be very careful. In multiple sclerosis, we use that word progression in a very specific way. And what we mean by that is we don't mean continued inflammation and continued swelling that goes on, continued attacks of the immune system, but a slow decline of the nerve or the covering of the nerve itself. And it sounds like what you're describing is not continued progression, but continued inflammation despite those medications. And the question then comes up is, are those medicines powerful enough, or are they affecting your immune system powerfully enough in order to reduce the inflammation that's going on? And that's where you and your physician can work together to try to figure out a medication that might be even more powerful in terms of reducing that inflammation, in terms of really squashing down the disease of multiple sclerosis as much as possible.
Thank you very much. We also have a question from Judy, and this will be our last one. You mentioned steroids in your talk, still being effective in reducing the inflammation during relapse. Why is it a trend toward not using them by MS neurologists?
The question was, if steroids still work and nothing's changed in terms of them suddenly not working, why does it seem like there's been a trend more recently where MS neurologists overall are using steroids less and less? Part of that has to do with the idea that neurologists who deal with MS believe that they're seeing less relapses than they saw beforehand. They think that the newer medications are having a more profound effect on multiple sclerosis and reducing that inflammation. And so there's less attacks that happen and less relapses. But that still doesn't explain why an individual person, if they're having a relapse, why they wouldn't be treating it with a steroid, or why they wouldn't be trying to reduce that inflammation.
Okay.
And so this bias of why neurologists are not necessarily treating relapses as much as possible is probably fairly regional. Probably has to do a lot with where a person is in the country. It has to do with whether they feel that the risk of the steroids are worth the potential benefit that may come from it. What I mean by that is, if the benefit of the steroids we think overall is reducing that inflammation and making that relapse shorter, then some people might say, well, all you're doing is making it shorter. You're not changing the eventual outcome of multiple sclerosis. So why take a chance with steroids? Every time you take steroids, you have potential risks. Some risks are weight gain. Some risks all have to do with bone health. There's an independent risk that happens each time in terms of bone health with steroids. But I would say overall, if you're still having relapses, if you're still having attacks that are happening, and your neurologist doesn't think that these are what we call pseudo attacks, or meaning not that you're faking, but that it's a bringing out, it's not a real attack. You got overheated and it's bringing out older symptoms, or you have an infection and it's bringing out older symptoms. If they really think this is a new attack going on, I think a very fair question for you to sit down with your neurologist and have a conversation with them about is, why don't they want to treat that with a steroid?
Wonderful. Thank you. Thank you. Thank you. So that's all the time we have for now. If you've missed any part of this conference, it will be replayed on msfocusradio.org and available on demand on our MS Focus SoundCloud page or our YouTube page. Remember to follow MS Focus on Facebook, Twitter, Instagram for times and access information. Our next teleconference will be this coming Wednesday, May 26th, actually a week from today, at 3:30 p.m. Eastern Time with Rosalind Kelb, PhD. She'll be talking about the invisible symptoms in MS. Our sincere thanks to all of our attendees for your participation, and especially to Dr. Kantor, who was kind enough to share this information with us. Thank you, everyone, and have a great day. And before we go, I just want you to know that when you leave tonight, you're going to receive a survey. We would really appreciate you filling it out. It's going to help us determine what you'd like to see, what you'd like to hear. It'll be a big help for us. So thank you very much. It only takes a couple seconds to do. Good night, everybody.